So we're going to go ahead and get started. Welcome to the University of Michigan Concussion Center Quarterly Speaker Series. My name is Steve Berlio. I'm the director of the Concussion Center, and it is my distinct pleasure to introduce our guest speaker today, Dr. Geoff Manley. Geoff is the Chief of Neurosurgery at the Zuckerberg San Francisco General Hospital and Professor and Vice Chairman of Neurological Surgery at the University of California in San Francisco. He is an internationally recognized expert in neurotrauma, and in addition to his robust clinical practice, he coordinates and leads national and international research efforts in the study of short and long-term effects of traumatic brain injury. He is the PI on the TRACK-TBI study and nationwide investigation on TBI outcomes. Following success there, he launched the TRACK-TBI Network, a precision medicine-driven consortium that will test phase 2 drugs for TBI. Geoff also sits on the National Academy of Sciences Engineering and Medicine Committee on VA examinations for traumatic brain injury, served as a consultant for Prehospital Guidelines for the World Health Organization, and on numerous clinical research committees for the NIH, CDC, and the Department of Defense. So he's quite busy. We are incredibly fortunate to have Geoff join us here today. So on behalf of the Michigan Concussion Center, please join me in welcoming him. I'm going to turn it over to you, Geoff, for about 50 minutes of presentation, and then we'll open it up to questions from our audience.
Sounds great. Well, it's great to be here today, if only by Zoom, and I appreciate that introduction. I think one of the things you've already learned about me is I have a hard time saying no. So what I'd like to do today is share my screen here. Can everybody see the screen? Good. All right, so we're good to go. So what I want to tell you a little bit about today is TRACK-TBI, which, as Steve said, is a study that really started as a pilot over 10 years ago and has evolved into a large collaborative research network. To talk a little bit about the design of the study, some of the early deliverables and the future directions, please feel free to reach out with some chats here if you have any questions as we're going along, and hopefully we'll have some time to answer some of these. So I'm trying to get this to advance, Steve, and it doesn't seem to be advancing. Let's try this. Here we go. Alrighty. So these are my disclosures. As Steve said, I have some funding from some federal agencies, philanthropic support from One Mind, from the National Football League, many grateful patients, and we have a large public-private partnership wherein we've received funding from Abbott, Neurotrauma Sciences, Quanterix, in-kind support, and so on. So I want to be very clear about the disclosures. So there's many faces of traumatic brain injury. I think for many of us, and I know a lot of the folks that are on the line here are really involved in the concussion world and certainly have been aware of brain injury for some time. But I think the general public, didn't fully appreciate this until the media coverage of what was happening in Iraq and Afghanistan. And of course, this is what you guys are very familiar with, which are these sports-related injuries. Wherein previously we were quite dismissive of this. And I think we understand now that there's at least a subset of these patients that do go on to have significant issues from this group. But I would be in the camp to say it's not none and it's not all, it's somewhere in the middle. And so I think some of the research that Steve and folks have been doing with the CARE Consortium and things of this nature are really helping us to get the kind of natural history data that we need to answer these questions about who is at risk and why, and what can we do to help folks not only prevent this, but also after they have these issues, what do we do about it? This is where I mostly work, which is in the civilian sector, as I refer to. We've got about 4.8 million people coming into emergency departments every year with traumatic brain injury. And, it seems like that every time we come up with a way to reduce traumatic brain injury, humans are just uniquely qualified at finding ways to continue to injure their brain. Whether it's, texting while walking, which I do not recommend. We have at least a couple of those people come into the hospital every week, slipping on curbs, running into light poles. Obviously, OSHA is good and industrial accidents are down. But just when you thought you'd fixed one problem, then we have another. I know now across the country, particularly urban environments are inundated with these scooters. Virtually no state has a requirement to wear a helmet when you're on them. We routinely have at least 1 to 2 patients a week that has a head injury from these scooters in San Francisco. So again, this problem isn't going to go away. And so we have to really try to understand better about how to deal with it. One of the other issues too is that most of us have been focused on sports and the things that we see with car accidents. And during this time of being worried about this, we have this rapidly growing population of traumatic brain injury folks, which are the people on the left. These are our parents. These are our grandparents. And, because the cancer docs and the heart docs and the joint replacement docs have done such a great job, we've now got a highly mobile group of people in their 80s, and they are having falls and they are hurting themselves. And so, we expect this to just continue to grow. And we started looking at this with the CDC maybe about 10 years ago. And what you can see here, looking at data from 2002, 2006, 2007, and then 2013, and I know there's more recent data that's about to be published, and you can see as you look over to the right side of these graphs, there's like this meteoric increase of trauma in these folks that are really over the age of 65. And we looked at that independently in California, where we have a lot of great data, not only on hospital admissions, but also on what happens with people coming into the emergency department and then being discharged from the emergency department. And what we saw is that in the last 10 years in California, there was a 40% increase in TBI. And a lot of this is being driven by the geriatric population and also the work that you folks are doing, helping to raise awareness of the importance of TBI. So more people are actually coming in and being seen. So as we look at 2020, we're still using classification systems for TBI that were developed over 4 years ago. And things like using the coma score to separate people into 3 crude categories of mild, moderate, severe, concussion really fitting into that mild group. And then thinking about outcomes really predominantly related to disability, like, are you back at work? And historically looking at people and saying, oh, well, it's fine if you're back to work. But, I don't consider that to be a recovery. I consider a recovery to be that you're back to work and you have no issues whatsoever. And so we had been binning these people, GOSEs of 7s and 8s together and saying it was a good outcome. But I don't think it's a good outcome if you have to go back to work and you're having crushing headaches, every couple of days. So we know now that just simply looking at things like vegetative state and good recovery, we're becoming more sensitive, as you folks have in the concussion realm, I think long before we did in the civilian realm, of trying to look at more detailed aspects of outcome than just simply, are you back to work yet? And so, noting that things like PTSD does occur in the civilian setting, seeing a large association with depression and cognitive changes and so on. So really what we've been trying to do here is to take, as Steve said earlier, is this precision medicine approach to traumatic brain injury, where moving beyond just simply looking at the symptoms here, we start really taking into consideration, what does the imaging mean? And certainly in the civilian space, not so much in concussion, but in civilian space, somebody that meets criteria for a head injury, and you can go look all those up. It's pretty easy to get a head CT scan if you show up at an emergency department with a history of a head injury. And so we actually use the CT scan now more for triage decisions than we do the GCS. And then the work with MRI has just been phenomenal over the last 10 to 15 years. And I know CARE and a lot of other groups have been using these techniques as well. And I think this holds a lot of hope for the promise for the future. And I'll show you a little bit of that data. Certainly there's a lot of clinical data that we don't fully, take really as part of what we're doing, because it's hard to harness, even though we have electronic medical records. And I think another area that's been of great interest across all these different types of head injuries has been the use of the proteome. Certainly things like troponin for the heart have revolutionized how we take care of chest pain. And I think, we're seeing now the early days of blood-based biomarkers that I believe, at least from a diagnostic perspective, are going to play an important role in trying to help us identify who's had a head injury and who hasn't. Also, we know that not everybody that has a head injury goes on to have a horrible outcome. And some people have outcomes that are worse than you would expect, and some people have outcomes that are better than you would expect. And so part of this is this notion about, what does the injury do to the brain? and then what is it that you bring to the injury? And so what you bring to the injury is all of your pre-existing medical conditions and your genetics. And we had papers from the pilot study that clearly showed that there are some genetic polymorphisms that are associated with functional protein changes that in fact are associated with unfavorable outcome in TBI. So I think that this is just barely scratching the surface, and we're starting to look at that now. So what is TRACK-TBI? It's much like CARE. It's a prospective longitudinal observation study that has 3,000 subjects, including controls, across the spectrum from concussion to coma. And I use that intentionally. Rather than saying from GCS of 3 to 15, I think actually some of these older terms like concussion and coma better capture some of the pathology that we're talking about, to really think about how do we improve diagnostic models and classification, outcome assessment. Are there better tools that we can be using in this space for outcome? Identifying the health and economic impact of mild TBI. And when I say mild TBI, I'm really talking about a lot of the patients that you look at, but just from a different mechanism. So nearly 60% of the people that are in this cohort of people that we've studied over the last 7 years actually have a GCS of 15. So they would meet the definition of a concussion from your world. I mean, they were knocked out in the field because they fell off their scooter. They come in, by the time they get there, they're GCS of 15. They know where they are. Everything's fine. It's like an athlete that cleared up on the sidelines. And yet, we know that maybe the mechanisms may be a little bit more profound. We're more likely to see a positive head CT. We're more likely to see findings on an MRI. So one way to think about this is that even though these are quote unquote mild or concussion patients by civilian standards, the mechanisms may be a little bit more significant or may not. So where are we? Well, we're actually all over the country, and we do have one of our colleagues who is at Michigan, who's an emergency room physician there that works on a lot of the biomarker work with us, Fred Corley. But these would be what some people would consider to be some of the top trauma centers, level 1 trauma centers in the country. Places like Parkland, places like Ryder in Miami, Harborview in Seattle, our place. I mean, these are high volume level 1 trauma centers where there is a selection bias because they're only bringing the sickest patients to us. This is our team. And for those of you who also cross over into the civilian TBI space, you'll recognize a lot of these folks. And Mike McCrae, who's also been involved with a lot of the work, has worked closely with Steve. And it's good to have this cross fertilization because, to go on record, I think that, we may not be doing ourselves any good by separating sports from military, from civilian. I actually think that really they're all external force injuries to the head, and we can learn more by working together than we can by working apart. And I think this is really what's guided us and brought all of us together, because most of us used to compete against each other for a very small pool of grant money. And I think what we found is that working together, we're getting further than working independently. And furthermore, we're all learning a lot. I really didn't know that much about outcome assessment or about long-term outcome and rehab, despite the fact I've been taking care of these patients for 20 years. And so I think this has been good for all of us because it's truly been this experience of the blind man and the elephant, where we were all looking at the same thing, which was a TBI patient, but I was looking over here at the trunk and somebody else was looking at the leg. And I think all of these different specialists coming together on a regular basis and trying to study this, I think we're doing a better job together. So what have we done so far? Well, in addition to these 2,700 TBI patients, we've continued to enroll some acute patients through some leveraging studies, which I'll just barely mention. We have 300 orthopedic trauma controls. So one of the things, at least in civilian TBI, is that we've had a paucity of controls, and so we needed to solve that. And the controls have been very, very important for us, through some of our early papers that we've been writing. And we have 300 friend controls. And so who are the friend controls? Well, these are friends of the TBI patients. And we find actually that the friend controls are more like the TBI patients than the ortho controls when we look at the socioeconomic background, things like prior TBI. And it gets back to the old adage, friends of a feather flock together. And so, we really are identifying, I think a very important control group that will help us to understand some of the sort of almost non-TB injury related characteristics of this population. We've got about 3,000 data fields on each subject. We have a battery of 21 outcome measures. We've got tons and tons of MRIs at 2 weeks and 6 months, lots of biospecimens for plasma and serum and DNA and all of that. And importantly, we have brain donation, which we started late into the study, and we hope to continue with another follow-on study that I'll share with you shortly. So in terms of the MRI biomarker imaging, we have both macro and microstructural imaging, where we're looking at extracting features from the TBI common data elements, and also looking at things like the volumetrics, looking at resting state fMRI, looking at diffusion characteristics such as diffusion tensor imaging. And importantly, we've standardized this. So we use ground truth phantoms so that we have a biophysical assessment of what is the structure and how does this particular magnet, because you know that not every magnet is made the same way, and even within vendors and even within the exact same production runs of these MRIs, there will be slight differences. And so what these phantoms allow us to do, and what you're looking at on the bottom is a diffusion phantom, where you're looking at different types of diffusion and different colors that are popping up here. So you can actually then set this up to where you get quantitative information. So it's not just qualitative, but it's quantitative, and that feeds into some of our big data efforts that we'll talk about. So one of the things that we saw early in the pilot, and we have now replicated in the current cohort, and so have our colleagues in Europe that run a parallel study to TRACK called Center-TBI, is that just simply having a negative head CT doesn't mean that you didn't have a brain injury. So remember, these are people that are coming to level 1 trauma centers, meet the ACRM criteria with loss of consciousness, post-traumatic amnesia, or alteration of consciousness. And this particular subject here was a patient of mine, a young woman who fell over the handlebars of her bicycle. She was, incredibly nauseous. She had repetitive questioning, but she had a negative head CT. But we couldn't really let her go because she wasn't fit to leave the emergency department. And what you can see here with the yellow arrows are these areas of microhemorrhage. And in a 23-year-old, you're not going to find microhemorrhage in a 3-year-old. And so we believe these microhemorrhages are associated with axonal injury. And but frankly, there's still ground truth to be had there, which is where the pathology comes in. The red arrows on the bottom left are a contusion that couldn't be seen very well on the CT scan, which was read clinically on the top left as negative. And this is just a graph showing you that, across our early pilot sites, we found that about a quarter of these folks with a negative head CT had findings on an MRI. What we saw with our current study, it was 27%, and our European colleagues found about 18%. So I think it's probably safe to say that even if you've had a negative head CT at a level 1 trauma center with a mechanism, for TBI, it doesn't mean that it rules you out for structural abnormalities. It means you may need a more sensitive tool for that. And this will continue to evolve as we look at the prognostic utility of these things, and so on. And I know everybody's been very excited about MRI, but CT actually got really better. While everybody was focusing on, diffusion tensor imaging and functional MRI and all these other things, our slice thickness got thinner. Our detectors became more, starting to do multi-slice. And so what you begin to see here, and this is a pretty complicated slide, we won't go into it in detail, but what it's showing you here is that even with when we say somebody had a positive head CT, there are all kinds of phenotypes of imaging in here, isolated subarachnoid hemorrhage being the most common. But the thing is here is that because of the collinearity, you can see that these things actually group together. And importantly, they group together in a very nice way that makes biomechanical sense. But I don't want people to lose sight of the fact that at least in civilian TBI, that CT continues to play an important role. And I think it's been underutilized in terms of looking at its prognostic significance for certain phenotypes, if you will, imaging phenotypes, because some of them are more prognostic than others. For example, epidural hematoma, like in severe TBI, isn't as prognostic as, say, for example, subarachnoid hemorrhage. I share with you a recent paper that was published in Science Advances, and we've got a ton of stuff out there, and you can find it just by sort of Googling TRACK-TBI. But this is a recent paper that I thought I would bring to your attention, looking at one of these new tools for looking at microstructure called NAUTI. And this is a pilot study in a subset of our patients. And in this panel, what you can see here on the left, blue means decrease, yellow means increase. And what you can see here is that we have early decreases in fractional anisotropy here that are associated with increases in mean diffusivity. And I understand from Mike and others that you're seeing a strong signal in the athletes as well with mean diffusivity. And that's why I'm saying it's important for us to work together, because when we start finding the same things, if we truly believe that this is along a spectrum of injury, it starts to make both our groups believe that we're actually finding the truth, which I think that's what's happening. And what you can also see is that this FISO, which is the bottom, this is giving us our free water measurement, and not surprisingly, the free water is going up. And importantly, these FISO measurements are actually associated with symptoms on the Rivermead post-concussion questionnaire, which you guys are very familiar with and use all the time. In fact, we borrowed that measure from the concussion world. So I think that this is still very early days for this particular tool, and it needs to be validated. But I think what we're beginning to think is that this may be, this and similar types of tools, this isn't the only one that does this kind of thing, will be where we will go after DTI, because there's been some controversy about, does the fractional anisotropy go up, does it go down, what does it do? And so it begs for some inherent questions about how reliable that would be to do on an individual patient. And so I think as we get to these more granular ways of looking at this, what we'll see is better tools. I mean, it's an iterative process. Now, I told you earlier that brain donation is going to be very important. And so this was one of our first patients whose family gave the ultimate gift, which is to donate their loved one's brain to science. And, we can't thank these families enough to do this. It gives us, I've used the word ground truth before, I'll use it again. I mean, you can look at all kinds of imaging sequences. And as we say in medicine, the doctor that has the ultimate say is the pathologist. And I think that that's really true here. And what you can see is this is work that's been done by Brian Edlow and colleagues, Bruce Fischel at the Martino Center at MGH Harvard. And, this individual, we had the opportunity to do an MRI scan before they passed. And then, after they passed, we were able to do brain imaging at very high resolution. So what you're looking at on the top right is tractography that's being done at 7 Tesla. And, this is exquisite tractography. That little red arrow points to this contusion that we were looking at in the ponds when we were, having family discussions about, because we'd been treating this fellow for 3 weeks and he wasn't waking up. And so what you can see up there is that these beautiful little tracks, some of them, being disrupted by this clot, some of them actually still going through this clot. And we have a paper that is in revision right now, describing this case so that you can look at this more in detail. And I think what we're learning now that we go through the actual brain sections and the staining and so on, we're really starting to put together a more comprehensive picture. So as has been the case in sports injury, I think getting brain donation is very important, and we're going to continue to pursue this. We now have about 15 brains from the cohort. Blood-based biomarkers. So this is one of those slices of the precision medicine stack, and certainly gained a lot of traction over the last few years. GFAP, UCHL1, tau, C-reactive protein, neurofilament light. And this is a slide that I think borrowed from Mike McRae, showing that, where do these things come from? Well, from the neuronal body, you can get NSE and UCHL1, which we measure S100 and GFAP from the astrocytes, and then looking at axons, looking at neurofilament light, looking at tau. And so we've been looking at a lot of these, just like you guys have in the sports world, trying to understand, what do these things mean? How do they relate to diagnosis? How do they relate to prognosis? And the reason why this is such a big deal is that, February of 2018, the FDA cleared GFAP and UCHL1 as the first diagnostic biomarkers for traumatic brain injury. But the thing is that this was really only for a narrow segment of the population, the GCS 13 to 15 within 12 hours. Not everybody presents within 12 hours, and we have a whole range of GCS. So just a few months ago, David Okonkwo in our group published a paper using this new point of care platform cartridge. So to be very clear, and again, I disclosed that we have had grant funding from Abbott and in-kind support for biospecimen analyses. The iStat's been around for a long time. They're used in emergency departments and ICUs all over the country. It's a tool that's been there. There's about 20 of these cartridges that are approved for things like troponin for heart attack, et cetera. And so this is a prototype. This is not FDA cleared. This is a prototype. This is still being actively investigated, where we're using this prototype that that looks at those same antigens that were cleared by the FDA, GFAP and UCHL1. And we compared this to S100, which is the European standard, Northern European standard that is used to determine whether or not people should get a CT scan or they shouldn't. So what we found, and you can see here, these are the receiver operator curve characteristics, wherein the closer that you get to the top left corner there, the better it performs with sensitivity and specificity. And so you can see that the black line is bending up there better than the red line is, which says that the receiver operator curve characteristics are better than S100. So in fact, it does outperform S100 to identify folks who have a positive head CT. But importantly, this works across the entire spectrum. It's not just GCS of 13 to 15, but in fact, probably performs better in the GCS 3 to 12. And as I said earlier, I'm not a big fan of those, lines of division. I think really what we need to start thinking about is, what is the GCS? Did somebody show with a GCS of 15? Okay, they had a concussion. Did somebody show with a GCS of 12? Fine. But let's talk about that in a more precise way. Don't call it mild, okay? Let's call it what it is. It's a GCS of 14 with a positive head CT. And importantly, this worked up to 24 hours. Another thing that we saw, and we saw this in an earlier study as well, is that not surprisingly, the more of your brain that's injured, the more of this protein ends up in your bloodstream. And it's the same story with troponin. If you have a big whopping heart attack, you'll have a lot of troponin in the bloodstream. If it's just a little troponin leak, maybe you're just having a little angina or a little, transient ischemia. And so this is kind of what it looks like for us, is that, as we get more and more burden of injury, we see more and more GFAP. But this is still an evolution, and papers still to be, written to dial all this in. Well, what about people with a negative head CT? We talked about that earlier. Does a negative head CT mean you didn't have a head injury? Well, no, it doesn't. And as I showed you before, we know that at least in our population, that about a quarter of these patients will have a positive MRI. So in this paper, which was published last year in Lancet Neurology, we asked the question, okay, in all these patients with a negative head CT, when we see these elevations in GFAP, does it mean that GFAP doesn't work? Or does it mean that GFAP is actually seeing something that we can't see on a head CT? And what this showed was, in fact, this is showing us something we can't see on a head CT. So again, these are receiver operator curve characteristics for GFAP and UCHL1. And what you see is that GFAP is actually very good at identifying people who have a negative head CT and have a positive MRI. So again, it is identifying brain injured patients in a more sensitive way than CT scan, and being corroborated by MRI scan. And like with the GFAP in sort of more complicated injuries, you can see here, looking at things like traumatic axonal injury, which is currently defined, at least by imaging characteristics, as 3 or fewer microhemorrhages, or diffuse axonal injury, which is 4 or more microhemorrhages. You can see a loading effect here of different amounts of GFAP, the GFAP being higher if you have more injury, again, making sort of common sense with this. So, the takeaway here is that I think that GFAP, at least in the civilian space where, people are presenting typically, an hour or 40 minutes or 30 minutes or whatever after their head injuries, the GFAP looks like it's going to be a good marker for brain injury. It seems to be more sensitive than a head CT because it identifies brain injured patients that have MRI findings. And importantly, if you look at that paper, you'll also notice that even when you have a negative MRI, the GFAP is higher than it is in the orthopedic controls. So what it says to us is that things like NODI and kurtosis and some of the things they've been looking at in CARE, that some of these more refined imaging features that are even more sensitive than a structural MRI are going to probably start to align with some of these higher protein levels, brain protein levels that we find in people that have had a traumatic brain injury. So I think that, these sorts of tools are going to pave a new era for how we manage these folks, how we do clinical trials. Certainly that's been the case for troponin. Today, troponins are ordered all the time. Anybody that comes in with chest pain, even if they just finished eating, a big, greasy meal, you're still going to get your troponin checked. Why? Because it's objective and it's easy and it's fast. And so I think we're going to see the same sort of thing that will happen here. And many many companies are pursuing this, and there's lots of great ideas, and that's what always happens at the the beginning curve of research in an area like this. But I think we're very, very close. We've already gotten clearance for one biomarker. They don't have that for Parkinson's. They don't have that for Alzheimer's. So and we need to, and I think we are going to need more sensitive things for concussion. But some of the early data coming out of CARE suggests that there's a role there as well. So when we start thinking a little bit more about how does this affect public health, it's great to do sort of translational research on imaging biomarkers and blood-based biomarkers, but how does this relate to how we're taking care of patients? And so we published a paper last year in JAMA Neurology where we looked at recovery after mild TBI in patients that were presenting to level 1 trauma centers, and this was led by Lynn Nelson, who grew up with Mike McCrae and the concussion community, and we were able to get her to sort of cross-pollinate, if you will, into our field, and she's been a wonderful investigator with our team. And it was really, identifying that this term mild TBI, I would just really hope that people stop using it, because it's not a precise term, because if you're not fully recovered by a year, there's nothing mild about it. And so we should just call it what it is. Somebody had a concussion, and some people recover and some people don't. And so, we found that patients were still reporting limitations. Well, what I mean by this, so our definition of a good outcome is full recovery. I think that anybody that goes to an emergency department and is told that they have a mild TBI versus a severe TBI, their expectation is that they're going to get better. And what we saw is that looking at people with a GOSE of 8, which means I'm back to work and I'm great and I'm just like I was before I had my head injury, versus 7, which means I'm back to work but I'm not. What you can see here is not only the trauma controls are also disabled. So this is why it's good to have a control group. And you can see, but the trauma controls with this green line, they just keep on getting better and better over time. And we followed these people out now 4 or 5 years, as at least a subset of them, and they continue to get better. Whereas, the mild TBI folks, they don't continue to get better. They have impairment. And importantly, and probably makes common sense, is that if you've got an injury that's significant enough to put blood in your brain, then, you have a much higher rate of impairment. And that was clearly shown here. Well, what's impaired? Why is it that these people aren't going back to work? Let's just take headache, for example. It's on the top row. Basically, patients that have had a head injury, 36% of them report headache on a Rivermead versus 9% of the ortho controls. And you can just go down through here. It's not the trauma that's causing this. It's actually the brain injury that's causing this. And we need to understand why these people are having so many symptoms. It's one of the largest effects that we see in this population of GCS of 13 to 15, and we need to understand this better. The other thing that we need to understand is we need to do a better job taking care of these people. So I proudly, stated at the beginning of my talk that these were some of the best trauma centers in the country, right? And they are some of the best trauma centers in the country. But, and part of our follow-up was to ask these patients, well, were you getting supported by your family? Were you getting supported by your employer? Have you seen a doctor? If so, what kind of doctor have you seen? And much to our surprise, we found that many of these people who were diagnosed with a traumatic brain injury had not seen a doctor. And so this is the data here. So what you can see is that by 3 months, only 44% of these people had been seen by any kind of provider. And I'm talking about chiropractor, general practitioner, neurologist. And if you look at the people that actually saw somebody in what would be considered to be a TBI clinic, and most of these were concussion clinics that people were sent to, it was only 6%. So I would argue that that's probably not a good idea. Why? Because, people have often thought, well, those people that don't go to a doctor, they're not having any problems. That's not true. Read this paper, because what we saw is that in those, 56% of the people that were not seen by a doctor, that many of them had symptom scores on the RPQ and scores on the BSI-18 for depression and things like that, that they sure ought to have been seen by a doctor. They needed to be seen by a doctor because they were having real issues that could be treated. So I think that we've got a long way to go in terms of filling in these gaps of care in this population. And frankly, I think that the civilian sector here has a lot to learn from our concussion colleagues, because you guys have been working out the bugs for years about how to run a concussion clinic. How do we take care of these patients? What do we do? Our our response to that was, well, we're not going to send them to see anybody. That's kind of simple, out of sight, out of mind. But I think the fact is that these people do have issues, and we're going to need to all work together to establish systems of care like you guys have already started to do in concussion. We need to do this with our civilian TBI as well. So to sort of wrap up this portion, there have been a lot of discussion about that PTSD, which doesn't occur a whole lot in sport, but does occur in the military and does occur in the civilian sector, that it was just maybe the trauma. It was just the traumatic event. It had nothing to do with the head injury. If you were exposed to a horrific, violent trauma, then this is what was going to happen to you. And so because we had these trauma controls, we were able to take a look at that. And what we found, and this is a paper that Murray Steen published last year in JAMA Psychiatry, is that patients with TBI are twice as likely to develop major depression and post-traumatic stress disorder than their orthopedic trauma controls. And I think this is a very important finding because it says that trauma plus an injury to the brain actually kicks something off and suggests to us that there's some kind of connection between brain injury and really developing this sort of pathology. And it's important because we don't know what causes depression. And I know there's a big depression center there at Michigan, and people have been working a long time trying to understand depression, and we still haven't cracked that. And so, I think there's some opportunities there to think about this. And, we've begun to identify risk factors, but certainly not all of them. So this notion then about what does TBI cause? Well, certainly we think about, when we think about military, we do think about, depression and suicide, unfortunately, things like PTSD, when we think about sports, everybody thinks about chronic traumatic encephalopathy. From civilian TBI, we know that this is an environmental risk factor for Alzheimer's and for Parkinson's disease. And so we know that there's a connection here, but we don't know exactly what the connection is because we've studied the hell out of people in the hospital, but as I just said, we don't even follow them up. So we really kind of lose track of them. And then we see these people downstream, and so many things happen in between. It's hard to kind of suss out, well, what was it? Was it the head injury? Was it some environmental factor? Was it something else that happened to these people? We really just don't know. So this was really the rationale for a pilot study that we're currently underway with that was partially funded by the National Football League. And I want to be clear with the disclosures here, but these are not sports patients. These are civilian patients that the NFL has given us some money to study long-term. And so what we've done here is that we're looking at 3,300 TBI and control subjects here. And what we're doing is we're sort of funneling down. We're doing phone follow-up with them, which has actually been, probably facilitated by COVID because we've got people at home and we're catching people, and actually found a lot of these subjects. And then, we are soon to bring these people back for follow-up. We were about ready to start early this year, but then COVID hit. And so, as a result, we've actually got some of these folks now that we've followed up by phone for 2 subsequent years, but we're about ready to start phone follow-up. And we are going to start offering prospective brain donation to anybody that's willing to, to sign up for themselves for brain donation for future studies when they pass, to better understand what was the impact of their trauma. So what you can see here, this is data from a couple of weeks ago. We have found 1,184 of these people. We've actually got the second follow-up on about 470 of them. Importantly, we have informant data on about 60% of these people. What do I mean by informant? This is a spouse, this is a relative, this is somebody they live with, this is someone that's willing to talk about the patient. And, because some people say, well, I'm great, I have no problems at all. And then, this patient's significant other goes, let me tell you what's going on here, and with our more significantly injured patients, a lot of these folks actually lose their insight into judgment as to what's wrong with them. And so this has been very important. And we're just now starting to look at this data. So I think this is going to be a very exciting project. We're hoping, despite COVID, to start getting some of these folks back for in-person follow-up, maybe by the end of the year. And this will start to give us a picture because some of these folks were enrolled all the way back to 2014. So some of them are already 6 years out. And this is very, 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 very preliminary data that I'm about to show you. We were just using this as a rationale to get this grant funded. We actually have been so busy with other things, we haven't had a chance to go back to this. But this was just looking at the first couple hundred patients we found. And again, very preliminary. But if you look at things like the TBI versus the ortho, and yes, there's only 113 TBI and only 15 ortho. That's why this is preliminary. But you can start to see that these comparisons look a bit like those symptoms comparisons that we saw from Lynn Nelson's paper, suggesting that these folks are really reporting, worse emotional and worse mental function. There's been some concern that there's a small subset of these people that, in fact, may start having some kind of dementia. Again, we don't know. This is all self-report. That's why we're bringing these people back. We're going to do a very careful dementia workup on these people. We're looking for post-traumatic epilepsy. We have a lot of things that we're looking at, but I think it's going to be very important as we move forward. So, as a clinician, somebody that takes care of these patients routinely, I think the precision neuroscience and the precision medicine approach is a great translational tool. But ultimately, how do we translate this to personal care? Some people come to me and they're like, "Hey, can you do like one of those really fancy MRIs on me and tell me what's wrong with me?" No, we cannot. All of this is group level statistics, and so I think to get to this level of personalized care with some of these tools, we're going to need a different way of looking at that. So I want to sort of wrap up today talking to you about one of our new partnerships with the U.S. Department of Energy. And, some people will say, Department of Energy, why Department of Energy? Well, the Department of Energy has national labs all across the country. I think maybe one of the closest ones to you guys may be Argonne, which is outside of Chicago. We have two in the region. We have the Berkeley lab and the Lawrence Livermore lab. There's Los Alamos. There's Oak Ridge, that's actually been doing a lot of work with prevents for suicide prevention and the military. Brookhaven. I mean, they're all over the country. And what you may not be aware of is that these are the homes to the fastest computers in the United States. So Sierra, which lives at the Lawrence Livermore National Lab, is considered to be one of the top 10 computers on the planet. They have a new computer that's coming online at Argonne. And so this is really where the United States invests a lot in computer infrastructure and gives us an opportunity to get access not only to high performance computing, but more importantly, card carrying computer scientists. So, this is sort of a dream of the future here where we've got artificial intelligence, we've got machine learning, we have all these things. But, as kooky as this is, I'm old enough, and I'm sure there's enough folks on this webinar here to be old enough to remember, when we would watch Star Trek and, look at what they were doing with Star Trek and think about that. I mean, hell, look at our cell phones today. I mean, this will come to us, and this data and this evolution that happens with this, I think will happen. And with studies like CARE and studies like TRACK, we now have mountains of data to start crunching with all of this. I think it's interesting that if you look at the papers that are being written out of these large consortia, we're still using statistical techniques, most of which were invented 100 years ago. So I believe that all of this is going to benefit from, better tools to look at this. I'll just give you a couple of examples here as we wrap up. So, this idea, I showed you this scan before, you got these invisible wounds and certain outcome. There's all this beautiful MRI tractography that we can do at a group level. But, starting to get to an individual level, things like a connectome. So what you're looking at here is a mathematical representation of connectivity in a patient's brain that's had a brain injury. And so we're looking at some nodes that have been knocked out. And so one of the things that we believe may be important is that as we built this huge reference set with the Human Connectome Project, can we look at these disconnected brains to try and get a better insight into what may be wrong with them? And could this really now be moving from group level statistics to more precise individual findings? The problem there is that the processing of these is not trivial. So if we wanted a real-time connectome, we don't have it today. And we don't have it today because of the timing that it takes for one of these standard pipelines. So this is a pipeline that Pratik Mukherjee uses for his connectome work. And you can see that there's sort of two parallel things that happen, and then sort of this all gets fused together to get this connectome. And this thing on the top left, which you can see the parcellation, this is a FreeSurfer that if you've done any imaging, you're familiar with FreeSurfer. It takes a long time to run. And even with rewriting a lot of the software, some of the software that we were using for this pipeline really was optimized in a very profound way by, doing some parallel processing and things like that. So we could speed that up greatly, but we really sort of hit a wall with the segmentation parcellation using some of the current tools that were available. And so this idea of trying to sort of get past, and I know there's other tools besides FreeSurfer, but FreeSurfer is, in my opinion, sort of the standard that you see written up most. And so how could we move this particular thing faster? And frankly, we just hit a wall. And so some of you may be familiar with this concept of deep learning. And so, with deep learning, some of the early machine learning was, we would look at a bunch of features and then we would have a human in the middle of it going, okay, what you're looking at there is the tail of a cat, and that's the nose of a cat, and that's the ears of a cat. And what this deep learning does is it lets the computer come in and it gets the human out of the picture, and then the computer starts to learn. And so you've probably seen some things online like, you could show a door handle to a computer that's been trained on a deep learning algorithm, and it can tell you that's from a 1966 Mustang, and it does it just like that. So the ability to use deep learning to try to figure some of this stuff out, our colleagues at Argonne, and again, this is very preliminary and still in the works here, but I thought it was exciting, so I'd show it to you, is what you're looking at here now is a deep learning approach to segmentation. And what this thing is doing is that the computer has figured out its own way to segment the brain, which is surprisingly accurate. And we're doing a lot of validation right now. And, we didn't want to choke it out by trying to do 122 segments or however many segments. But it's getting better all the time as it continues to learn and it continues to see and to do more. And so, this algorithm to run this takes approximately a minute. I think is a little too generous. It's probably more like 2 minutes, but it's certainly not 6 hours. And so these sorts of tools, I think, will allow us to bring things like the human connectome to the patient's bedside. In addition, we've got just mountains of data. And as I said, typically we've been looking, the data I showed you today was, well, what does a blood-based biomarker look like in relationship to an MRI scan? But I showed you also, we've already looked at 40 different blood-based biomarkers, and now we've got GWAS data, and we're not just saying positive or negative head CT. I showed you this very complicated figure of all of these different imaging phenotypes. I mean, what do you do with all this data? So this is from Chris Bouchard, who's one of our colleagues at Lawrence Berkeley Labs. And so the way that he thinks about this is that, you sort of build these landscapes of like all of this data, you just put everything in there. And if you look over on the bottom right, this is our outcome space. And so this is our like 21 outcome measures actually at the item level, which seems to identify these clusters of different kinds of outcome space. And then what he does is that he does predictive mapping. Well, what does predictive mapping do? It's really sort of looking at diagnosis through prognosis. So you've got these different kinds of outcome spaces. And then, you've got these different sorts of stratification or diagnostic tools, and you're really setting up a diagnostic model through how well these different subgroups prognose outcome. And what you can see from this using this predictive mapping approach is this is just people with a GCS of 13 to 15. And based upon this analytic approach, it says there's probably about 25 different types of people, what we would call mild TBI. That's probably all. I mean, if there's 200 kinds of blood cancers, there's probably at least 25 kinds of mild TBI. There's probably more than that. So again, very preliminary data, but it shows the promise of using some of these high performance machine learning AI tools to really push our field forward. So to sort of wrap up, I think we're in a golden age now. I think there's been more interest in TBI, certainly in the last 5 to 10 years than there were in the first 10 years of my career. And I think it's more than just TBI. As we sort of alluded to earlier, I believe that TBI is also going to be a key to understanding the brain and really how it works. This idea of taking injured brains and looking at connectomes and comparing them to normal brains and started saying, well, how does this work? I mean, the Egyptians were doing this over 2,000 years ago. They would see that somebody that injured themselves on the left side couldn't move the right side of their body. And then they found that people had left-sided injuries couldn't talk. So this notion of breaking something to see how it works is not new. And how does this relate to Alzheimer's disease? Is it related to Parkinson's? We know for sure that it's related to epilepsy. TBI is a big cause of post-traumatic epilepsy. What is this connection to CTE? And I think in finding these connections out, we're going to learn about things like neuroplasticity and repair. We're going to maybe learn about what are some of the biological substrates of depression. So I think there's a lot of things that are exciting. So what I'll leave you with here and open up for any questions is really sort of this collaborative timeline. You know, I'm the talking head today, but I represent all of those people that you saw on the slide. This is truly a team effort that would have never gotten past, you know, year one without everybody working on this. You know, whether it was, you know, Fred Corley helping us with our blood-based biomarkers, or, you know, it's been Pratik Mukherjee with the MRIs. I mean, I could list 75 people here and growing, because, you know, we're always interested in finding new collaborators. We are really promoting the hell out of young investigators. I think we've had, like, I don't know, maybe 9 or 10 K grants, and some of the K grants have evolved to R grants. You know, we need to be growing our field here, and big data sets like this are a way to do that. So, you know, I think that we're starting to look at, you know, diagnosis. I think we're starting to think about how could we build better clinical trials. And at the same time, you know, I think we're asking questions that can be solved today. This system of care issue is something that we need to fix. You know, we need to make sure that our emergency medicine colleagues can refer somebody out to a clinic that can actually take care of these people. I think we can learn a lot from our concussion colleagues about how do you run a clinic? How do you do this? I mean, we need to do this. And this doesn't require a new biomarker. This doesn't require a new drug. This requires a system of care and getting some policy people in there and making sure that people understand that there's enough disability out there that this is needed. So I think it's a very exciting time. I think that we get closer, you know, every month to finding more things out about our patients. I think this opportunity to bring concussion in with the sort of the civilian sector and with military TBI, bringing all these things together is the way forward. We all need to work together. We need to learn from one another. And the future remains very bright for me. And more importantly, it needs to for all the people that we take care of, because, you know, unless you've had one of these problems, you don't realize the lack of anything that's out there for you. So let's all continue to work together. And I appreciate the opportunity to speak to you today about TRACK-TBI. Thank you very much.
Thanks, Geoff. That was an incredible discussion around TRACK-TBI. Really appreciate your time today and sharing everything that you and your team have done. Thank you to all of our viewers for joining us. I hope you got as much out of it as I did, and I would encourage everybody to join us in the new year, January 28th, 2021. Dr. Willie Stewart from the University of Glasgow will be joining us from 4 to 5 p.m. Eastern Time via Zoom, and he will be talking about chronic traumatic encephalopathy. Is it a major issue or a minor trend? See you soon.